Good afternoon, everyone. Hope everyone enjoyed the morning sessions. As Michael Veilleux noted earlier today, our sponsors enable us to offer scholarships and keep our fees minimal. Our platinum sponsor continues to be Molina Complete Care, and I'd like to introduce Juan Oristobal to say a few words and introduce our next panel.
Good afternoon, everyone. I hope you had a great lunch break. And as Nick is saying, I was supposed to welcome you this morning, but we had some issues, as always, they always happen. My name is Juan David Aristizabal with Molina Complete Care. And I'm not only part of the planning committee, but also a proud sponsor of the conference. Molina is a managed care company with presence in 20 states. We serve about 4 million lives through our Medicaid, Medicare, and Marketplace programs. Here in Arizona, we have a contract with Access to serve our members in the central region, which are Maricopa, Pinal, and Gila counties. We not only serve our members, but also the community at large. And health literacy is a key topic for Molina. We provide free educational classes on a variety of topics for community members that are not just members of the Molina Health Plan, but members of the community overall. Molina is huge on addressing social determinants of health, which at the end of the day will impact access to healthcare services and healthcare outcomes. We're proud sponsor of the conference, and we're happy to be here for the last 3 years. So thank you for being here, and thank you for having us. Thank you, Nick. And now I'm going to introduce the first of our panelists today, because it's a nice segue. I was supposed to do this panel, so it was really good to just have that intro right there. So our first panelist is Noelle Veilleux Markham. Did I say it right?
Yep, you got it.
Close to. Okay, thank you. Well, Noelle is an RDN and serves as the population health dietitian at the Arizona Department of Health Services. Noelle has 9 years of experience as an RDN and has spent the entirety of her career in public health nutrition with a focus on nutrition messaging and policy, systems, and environmental change strategies. Noelle, please take it away.
All right, wonderful. Thank you so much. I'm really happy to be here with you all today. Let me just pull up my slides and I will get started. Oh, just a second. All right. Thank you for that wonderful introduction. As Juan said, my name is Noelle Veilleux Markham. I've been at the Department of Health Services for about coming up on 9 years working in public health and public health nutrition. And so I'm really excited to be here with you today and share one of my most recent projects that really examines thinking about the language that we use when we're crafting our health messaging, thinking about promotional campaigns, posters, pamphlets, handouts, those kinds of things that we create to reach large audiences, and really reflecting on the language that we use. And so I'm going to share a resource that's called The Language of Health with you all, and talk about how I've used that resource and maybe some new ways to think about approaching how you might craft your own health messages as well. So as an overview for my time, I'm going to start off talking a little bit about weight stigma and considerations for how weight stigma can be prioritized as we start thinking about our work and our health messages. We'll take a look at the connection between weight stigma and how messages are perceived by audiences. And then from there, we'll move into some examples and strategies for framing messages that are still accurate and consistent and persuasive, and some of the resources that can support you in that work going forward. So one of the reasons that I'm really thankful to be here with you today is because that stigma reduction, and in particular weight stigma, is one of the reasons that this style guide was developed. In the world of public health nutrition, there are a lot of ways that stigma can show up in the ways that we discuss food and nutrition and health and weight and movement. But in particular, for me, starting my career working in obesity prevention, there's a really strong perspective in how messages and education materials and marketing campaigns have focused on individual behaviors as the primary tactic for promoting health and weight change, despite the potential harm that could come with perpetuating weight stigma. But thankfully, in the last few years, it seems like there's really been an increase in opportunities to view health in multiple dimensions, right? And having the opportunity to prioritize how we consider the impact of our messages and the negative attitudes and beliefs that can come with that, and take that into account when we think about our work. And one way that we see this is here in 2021, Nature Medicine published an international consensus statement for ending the stigma of obesity. And I'm just going to read a portion of their pledge here that states, individuals affected by overweight and obesity face a pervasive form of social stigma based on the typically unproven assumption that their body weight derives primarily from a lack of self-discipline and personal responsibility. And within that statement, they also cite that across the globe, people with higher weights face societal devaluation, negative stereotypes, prejudicial attitudes, and unfair treatment because of their body weight or size. And then we can continue to see that consideration in this paper as well, which is outlining the rationale for adopting more weight-inclusive health policies. And in this paper, they present 5 assumptions that are often driving health policy and messaging that we see. And so here I've highlighted assumptions number 4 and 5 that state the assumption is that weight stigma promotes weight loss, and that recognizing one is overweight is necessary to spur health promoting behaviors. And so let's see what that looks like and consider, how does weight stigma affect the health messages that we create, and how do those messages land? And so here's a paper that looks at the perceptions of obesity related messages. And in this study, they showed participants 30 types of obesity related messages. They all had an end goal of something about obesity or moving toward that healthier weight range. And they recorded a variety of responses from the participants. And how did they view these messages? What did they think of them? Including capturing messages that people were most likely to comply with. So they wanted to see, of all of these messages, which one resonates with you most and makes you feel like you're most likely to take action on that. So on this side, you can see some of those categories. We have physical activity, portion sizes, messages that are coded as being stigmatizing, or messages that cover multiple topics. And what they found was that most messages across the board scored pretty well with intention to comply, except for those that were coded as stigmatizing. And so the messages that were coded as stigmatizing had a notably lower percentage of participants who intended to comply. So those messages performed the worst. And it was found that the messages, the public health messages that focused on making behavior changes like increased fruit and vegetable consumption, increased physical activity, focusing on that health promoting behavior in a non-stigmatizing way, had the most positive ratings and the highest intentions for compliance. And the messages that were perceived to be most positive and motivating made no mention of obesity at all. So taking that into consideration, so what do we say and how do we say it and what does that look like? And this is where a resource like the Language of Health comes into play, and one of the reasons why it was developed. We really wanted a tool that could provide guidance and a framework for navigating how we can communicate about important health topics effectively, but in a way that mitigates unintended harm or unintentionally perpetuating stigma. And this is the preface that's included in the resource, and I'm paraphrasing, but basically what it says here is, what we say and how we say it matters. Our words help to shape beliefs and attitudes and behaviors. So it's not just behaviors, and we can acknowledge that. It's not always just about behavior change with the impact of our words. And to help make sense of this within the Language of Health Style Guide, each topic contains a section for effective messaging strategies and strategies to avoid. Effective messaging strategies are those that are well received, messages that people respond to in the way that we want them to. Strategies to avoid then is the opposite. Those are strategies that people don't respond as well to. And so throughout the rest of the presentation, I'll have some examples with call outs. And those call out boxes are examples of different messaging strategies that you could find in more detail in the full style guide. Overall, one of the main takeaways from the style guide and communicating health topics in general across the board is that we want our health messages to be audience focused and practical and positive. And so if we take a look at each of those, really for the audience, understanding that it's not one size fits all, one message isn't going to work for everyone. Being practical and knowing that health messaging can get really confusing really fast, even if we're doing our best to keep it simple. So messages that are actionable and clear are going to be better received by our audiences. And then being positive, particularly the last couple of years have been really tough for people, for everyone, for so many reasons. So being able to provide messages that capture some hope or some optimism is something that people respond well to, and could just frankly, I think we all feel that we could use a little bit of that right now, some positivity and optimism infused into our lives. So this is a slide of sort of the process that I've adopted once I started using this resource and developing social media messages or evaluating other resources that we potentially might have used in our program. But first, kind of thinking about what am I trying to achieve with my message, or what is the message trying to achieve in general? Is the focus truly on a weight change, or is that really kind of an avenue where we're looking at health promoting behavior? Then thinking about the strategies, either what's going to be appropriate to use and what things can I be aware of to avoid, even that I might develop on my own to be aware of that. And then lastly, kind of zooming out and thinking, big picture, what else is there to consider for this audience? Is there a cultural consideration or preference, something about the circumstances of this particular audience that is unique to this audience that I need to take in mind that might have an impact on how this message could be received from them? So here's an example of two different messages targeted to people that are pregnant. On the left, we have a snippet from the National Institutes of Health Pregnancy for Every Body campaign. And you can see right off the bat that, there's language that says any body shape or size can plan for a healthy pregnancy. And then it does go into the next sentence calling out that there might be certain higher risk factors for people at a higher weight, but really going out of their way to highlight that no matter your body shape or size or your weight, that a healthy pregnancy can be an outcome for you, and working with your healthcare provider to reach that goal. Contrast with the example of the message on the right, which is really, going targeted, really focused on calorie counting, some assumptions that, weight gain and pregnancy is attributed just to that individual behavior and sort of this ravenous, uncontrolled eating that we're assuming about somebody. And so it really has more of that negative tone. And so there in that call out box is just focusing on the positive and noticing the difference in a positive framing for talking about health and managing weight gain and growth during a pregnancy in two different ways. That's not to say that there's not a benefit to eating an overall healthful diet. There is. I'm a dietitian. I was trained and believe and know that foods serve a nutritional role and value for our physical health. But it's difficult to achieve that. It's difficult for people to achieve an overall healthful diet if they don't have a healthy relationship with food. Okay, if we have an unhealthy relationship with food, it really has the ability to intervene in the food choices that we're making. And secondly, food is really about more than just fueling our bodies. And so what can we do to keep that in mind with our messaging? So again, framing things from that gain perspective, really being positive. What can we gain from the foods that we eat? Focusing on what can be gained or the positive aspects like enjoyment can help people see food from a positive perspective. Messages that promote a healthy relationship with food acknowledge the many reasons that people eat so that people can go about their lives and choose the foods that are nourishing to them and meet their nutritional needs, but also bring them enjoyment and that taste good and help them have that healthy, balanced relationship with food in their lives. And this is important for us to remember, even if our role is to help promote behavior change to support health, and just recognizing that people are not always going to be motivated by health, and there are other things that impact our food choices. And we can see that here in this survey, 82% of people said that they didn't want to give up the foods that they like in order to eat healthier. And so, with that, we can see the reasoning for the idea that messages be framed on what can be gained versus lost, because people don't want to give up those foods that they like, right? So framing it in that positive way helps keep it in that place of how can you still infuse the foods that are valuable to you, that mean something to you and that you enjoy. Putting foods in like an avoid category or kind of pitting foods against each other can be really oversimplistic, but it can also cause people to kind of disengage and might have them abandon just the idea of making any dietary changes altogether. So here's another example of a food advertisement. So take a look at this while I read through the text and maybe just think about some of these ideas about effective messaging strategies or maybe some things that we might want to avoid. The ad copy says, "At Wagamama, we create food that makes you feel alive. Food that nourishes and energizes, like our comforting yakisoba, fueling you with the good stuff so you can be out there enjoying the things that you love." And so right off the bat, I love at the top, there's this idea that food is meant to be enjoyed. We create food that makes you feel alive. That's really positive. Focusing on intrinsic reasons to eat healthy, food that nourishes and energizes you and comforting yakisoba. And focusing on the positive right there at the end, so you can be out there enjoying the things that you love. We'll take a look at another example here. This is for a plant-based food item, and it says, "Explore the plant-based possibilities." And so on the left there, I have highlighted, that food is meant to be enjoyed, and explore and possibilities really kind of tap into this sense of like creativity and adventure and trying something new. And they're using that to kind of be enticing about this, right? Compared to on the right-hand side, focusing solely on nutrients, plant-based foods, there's a lot to be said about plant-based foods as a category. Lots of health talking points that you could make, right? Plant-based diets are known to be very healthful. You could really come up with a lot of content around that, but they chose not to do that here. There's no emphasis, anything mentioning cholesterol or saturated fat or protein, none of those things. There's no harsh emphasis focusing just solely on the nutrients. And that's something that's found to be a strategy that isn't as beneficial. Messages that are broad like this, that center on enjoyment and taste and things like that really land better with people than focusing solely on something like health or the nutritional benefits of a food. And then the last one I want to look at comes from a youth campaign. I wish I had it cited here, but I think I pulled this before it was officially launched. So it didn't have all the logos and tags on it. But this was a youth campaign that was targeted at influencing food and activity behaviors, and ultimately was an obesity prevention campaign. And so sugar is something that's very commonly highlighted in that landscape. So we'll take a look at this one. The message says, sugar holds you back. Sugary drinks don't give you long-lasting energy. They actually make it harder to do basic tasks. See how to refresh right. So here we can see two examples of strategies to avoid messaging strategies that don't work as well. The first is using negative messages. Sugar holds you back. So that's obviously not something that's sort of positive or something that we gain from that. It has a negative frame to it. And then the other one, looking down to the wording about, learn how to refresh right, that comes through with a strategy of the way that we have a tendency to discuss food or diets that must be, perfect or clean. And not only is this ineffective in terms of a messaging stance and how people respond to it, but there is actually real potential to be harmful as well. Particularly, for me, if I'm thinking about youth that are just kind of gaining some autonomy and taking on maybe more responsibility and making their food choices, I really don't want them to develop this way of thinking that categorizes food as good or bad, black or white, without any room for nuance or all those complexities that we talked about that inform food choices. And having that kind of mindset can really set us up for potentially disordered eating behaviors or even developing into a full-blown eating disorder. So there are definitely instances where it really does pay to be mindful of how we're framing things and thinking about the context that our audience is, not just with our message, but the overall messages that they have in their environment as well. And so that's one I really wanted to highlight and call attention to. So I just want to recap and bring us back to sort of this process flow that I mentioned earlier, starting with thinking about, what am I trying to achieve with my message, thinking about those strategies. Is there anything else to consider, and what am I trying to achieve? Most often in my work and perhaps in yours as well, whether it's prevention or chronic disease management, is there some type of health promoting behavior? And so do we really need to focus on something like weight, or can we focus on something more that, a health behavior can have positive impacts on health regardless of weight change? Thinking through those effective messaging strategies that we want to use, are we talking about multiple dimensions of health? Are we being positive versus negative? And then big picture, what else do we need to consider? I provided some examples today that had to do with pregnancy, in particular pregnancy for people in higher weight bodies. What might be some things to take into consideration if you're creating messages for a particular audience that has some specific need, where we can really make a difference? Does our messaging invite someone in, or does it put them, on edge, on the defense? Are in food and nutrition, there's just a whole host. Traditional foods, that's huge in the world of nutrition and dietetics right now, really kind of thinking of for being culturally appropriate. All of those big picture cross-cutting things, need to be taken into account, because there isn't going to be one size fits all. And so making sure that we pause and have that moment of reflection with our messages, big picture, is something that we want to make sure that we're doing routinely as well. So then to close, I just want to share, so this here is the full resource for the Language of Health Style Guide. All of the strategies that I highlighted on the screen, as well as a lot more, are included in that full resource. There's also lots of citations and additional resources embedded in there as well. So if this is an area of interest for you, I really encourage you to kind of go to the link, check out the full resource, and you can kind of dig around in there and see there's just a wealth of information. And then the other thing I wanted to highlight is the Yukon Red Center for Food Policy and Health. And they have a lot of resources dedicated to weight bias and weight stigma. In particular, they have some resources related to media. They have media guidelines as well as the media image bank. So Today, I've talked a lot about thinking about the words that we use in our messages, but there's also some additional resources that take into account, those visual components and how we're portraying people in larger bodies. Is that positive? Is it stigmatizing? All of those factors. So that's something that can pair very nicely with the language of health as well. And here are my citations from the different articles I mentioned. And with that, I think we have a few minutes for questions. So I will go ahead and toss it back over to Juan.
Thank you so much. That was a great topic and right on time. I don't actually see any questions in the question and answer chat box. That doesn't mean people can ask at the end of the whole session. So if you come up with a question later on, that's fine. We can come back to Noelle and you'll be here, right? You are going to stay until the end of the
Yep, I'll be here, and I can put my email in the chat as well. If people want to shoot me an email, if they think of something later, that's totally good too.
Thank you. That sounds great. Okay, well, let's move on to our next two presenters. We have Dr. Carolyn Cutilli. She is a patient education specialist at Penn Medicine and past president of the Healthcare Education Association, HCEA, and co-chair of the HCEA's Patient Education Guidelines Work Group. Her scholarly work focuses on geriatric health literacy, and she has obtained grants in health literacy and communication. Carolyn has published extensively and speaks nationally and internationally. Welcome, Dr. Cutilli. Now we also have Sarah Christensen. She is the Director of Patient Education at the University of Texas MD Anderson Cancer Center. She leads a dynamic team in creating health literate content and providing reliable resources to patient libraries. Sarah is the co-chair of the HCEA's Patient Education Guidelines Work Group and incoming chair of the National Cancer Patient Education Network, CPEN. Ladies, please go ahead and just do your presentation. Thank you.
Thank you.
Thank you so much.
Hang on a second. There we go. Was having a slight difficulty, but it took care of itself. Now I just need to bring this down to see the slideshow from my toolbar, and we are good to go. So you've already had the introduction, so we will move on from there. So how did we go about with developing the guidelines? Well, we kind of had this big idea. And we thought there's nothing out there that is a concise evidence-based tool for frontline staff that has real world clinical application. There's some proprietary products out there. I won't name who they're made by, but once again, there was a cost involved in that. And some of those have been done quite a while ago. So we decided that there really was a need here. We had developed the scopes and standards of patient education. So that was a good springboard. And we had looked at certification in patient education, however, was not ready to go down that trail yet, just due to the financial implications of it. But we thought what we could do is take a look at the literature, really do a thorough review of the literature and come up with guidelines. So what did we already know? Well, we knew about the suitability assessment of materials from 1996 from Doak and Root, which was wonderful. And by the way, Cecil Doak just passed away recently, and we were all paying homage to her on the health literacy website. There's the CDC health literacy website that has tons of information, the CDC Clear Index Guide, etc. Always use TeachBack, and then the ARC Health Literacy Universal Precaution Toolkit, and then the PMAT. Now, the one thing about the quick tools like the CDC Index and the PMAT is they kind of focus on an end material product. They don't really do the whole educational process. And, you know, the Universal Precautions Toolkit kind of gets into assessment, planning, implementation, evaluation, but it's 212 pages long. So we felt as though we needed to make it more concise. And the CDC Health Literacy website has pockets of information here and there, but nothing that pulled it all together. So that's why we felt as though we need to have something for frontline staff that was comprehensive but concise. And I have to tell you, that is the thing we struggle with over and over again as we were working on this project. Oh, I think something got skipped here. There we go. The other thing that really nicely fell into place as we were getting ready to publish is the Healthy People 2030 definition. And so, you know, we've had a personal definition since the year 2000. We've never had an organizational definition. And what we've learned through the research and projects we've done is that the chance of dramatically changing someone's health literacy is not really great unless you do it in a specific target area, which is why we have like 180 tools in the Boston University tool shed of health literacy tools. So maybe if you use a diabetic health literacy tool, yes, you might see a change, but on the whole, the tools we have out there, you're not going to see a tremendous change. So what's the message there? The message is that us as healthcare professionals really need to make a difference here. We're the ones who need to, as the definition says here, equitably, emphasize equitably, enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. So the other part of this definition is it really opens everything up. I mean, health literacy is anywhere from, can you find the way to get to your mammogram, to do you even understand the results of your mammogram? And so it is a very broad, wide field.
All right, so HCEA knew that we needed to put some sort of plan in place. So Carol and I were happy to lead this effort, but we needed a team. We knew this was going to be a tremendous amount of work. So we were able to gather 27 volunteers to assist in the effort. We also knew that the literature search would be key to our findings. And so a grant was submitted to the National Libraries of Medicine and secured for the library search. What we really wanted to focus on with that grant was looking at the patient education API process. So assessment, planning, implementation, and evaluation. So our library search was challenging, and we went through many iterations of questions we wanted the librarians to search for, and results were coming back with tens of thousands of articles, and we knew that we had to narrow it down. You know, we wanted to keep the scope broad and general, but also concise and refined. So it was really quite a struggle, but where we landed is having 4 pointed questions. So question 1 looked at the assessment and really looking at what are the techniques that are best for assessing the patient's learning needs, their preferences, and their priorities before teaching, and also including elements of what is the patient's literacy level. For planning, we looked at the elements of the teaching plan and how it incorporated patient and family-centered goals, individualization, and measurable outcomes, also looking at the patient's literacy influence. Question 3 was on implementation. How do healthcare providers individualize the teaching strategies to improve the patient engagement and the health outcomes? And again, taking into mind the patient's literacy influence. And lastly, evaluation. How do clinicians determine what learning has occurred? So with those criteria in place, we narrowed it down to 10,000 articles from 9 different databases. The librarians did a superb job of finding this content, and then we imported it all into Mendeley. So we had one source to address all of the different titles for all of our different volunteers. We went with a very simple method in the beginning, which was to sort all of the titles alphabetically by title. And then we assigned viewers to each of the segments to look further in depth. They were reviewing the title and the abstract to determine if it was even pertinent to our API process. Any articles that were included in the sort but didn't quite meet our goals were moved into an archive file. We didn't delete them, we just moved them aside. And our running joke was that no citation was left unread. So from that original poll, we narrowed it down to 354 citations that we wanted to review in depth by looking at the full article and the findings from each article. So our in-depth review, we knew we needed to capture a lot of data. So we created a Qualtrics form and wanted to have the same criteria, the same kind of review process for every article that was identified. So what we asked every reviewer was to capture, who they were, title the document, give a description of it, what was the Melnick level of evidence, what was the criteria used for the research, which one of the API processes did it address, and many articles included several of the elements. They might have assessment planning as well as evaluation, for example. And then explain their choice of the API, summarize the findings, and then what was helpful in looking at so much data was really looking at what are the major strengths of this article or the findings, and what are the major weaknesses. And then we also asked for them to provide information of how the article supported the guidelines and any additional comments. So throughout that process, additional articles were eliminated. So we ended up with a total of 252 final articles that we used in our citations for the guidelines. Carolyn, to you.
Okay. So what we did next is look at summarizing the literature. We regrouped all the citations into the API categories. And that meant that some articles were in all 4 categories, maybe they were in 2 or 3. And then we assigned teams of reviewers for each API area. And the reason we did that is we felt at this point, we really need to concentrate in each one of these areas so that we could begin to understand what the results of the research was that we were seeing. So each article had 2 reviewers. The first reviewer went in and entered a strategy summary, what they saw from the research article, and then the methods used. The second reviewer went back, looked at the article, and verified the first reviewer's findings or disagreed, and then added their comments. So then we went on to writing the guidelines, and we're like, well, should we mix it up? Should we have people look at different areas of the guidelines, blah, blah? And we just decided once you were kind of like, I was really into planning and implementation. That was the literature I had looked at. So we just decided that the groups would remain where they were as they had looked through the literature. So we reviewed all the summaries. We looked at some of the most common interventions that were used or novel things that were also used that had good research behind them. And then we placed the interventions into a table with examples or sample scripts. And we added additional tools into the appendix. And we also kept in mind the gray literature, which might be dissertations. It might be a government report. It may be, like the CDC's recommendations on something or ARC's recommendations. So we brought all those items in also besides the research studies. So what did we begin to find? Well, one of the things we found, and partly this is driven by the questions that we asked, is all these concepts were seen in every part of the API: patient-centered, patient engagement, plain language, and focus on behaviors and actions. So we're like, well, we don't want to be redundant as you go through the guidelines, that appears in every part of the guidelines. So what we did is we pulled them out as overarching concepts. So keep this in mind. When you look at the guidelines, we still have overarching that patient ed should be patient-centered to be effective. It should have patient engagement to be effective. It should have plain language to be effective. It should focus on behaviors and actions to be effective. And what we found is the best practices combine all these elements. Education is an interactive process focusing on the patient's desired behaviors and priorities. Yes, we have things that we need the patient to learn that maybe they don't have high on their list. But at the same time, we really have to, the things that are high on their list, we need to address so that we can get their buy-in later on. So this gives you an idea of the table of contents, and we're hoping we can take a little trip to the website in a little bit. So there's a guidelines homepage. There's frequently asked questions. There's the assessment, planning, implementation, evaluation sections. There's appendices. We have references according to the strategy under each of the sections, and then references alphabetically. And then we have a quick guide that takes you through everything.
So as we were drafting the document, we wanted to get feedback, and committee members provided continuous feedback as we went through the development of the guidelines. We also took an initial draft to the HCEA conference where over 100 participants looked at the different sections and gave us some qualitative input. All of the feedback was reviewed, and anything that was supported was incorporated into the guidelines. So again, we were looking for something that was concise and would address frontline healthcare professionals' needs. After our initial draft, we had a final draft. And so we developed a 6-question survey that was sent to multiple groups of healthcare professionals. All the data was reviewed again, and the comments were discussed within the guidelines work group. We incorporated changes that we saw, and again, supporting the ultimate goal of something that was concise. In total, we had 42 responses from a variety of disciplines, and we used a standard Likert scale to find their satisfaction. And overall, the feedback on the final draft, the feedback was very favorable in support of what we had drafted. And the questions that we used with the healthcare professionals was, how did we do in explaining unfamiliar words or concepts? And were all the important aspects and strategy of patient education included? Were the sample explanations and scripts helpful? Were the appendices helpful? And then we asked if they would implement at least 1 or 2 concepts from the guidelines in their practice, and if they thought that the guidelines could be implemented in the workplace. So what we're going to do now is just give you a very high level of the 4 sections of the API process, and then we'll have a little bit of time. Carolyn will actually show you our website as well. So for assessment, we defined it as effective patient education is based on a learning needs assessment. And the 5 steps for assessment include looking at the social demographic, as well as support systems, cultural values and beliefs, and barriers to learning. Secondly, assess the learning needs based on current health issues and knowledge and worries. Third, the patient engagement, as we've spoken about before, and how involved are they in setting the goals and their motivation. Then looking at the learning preferences, and finally, what specific assessment tools could be used in this step.
So the next part is the planning, and Sarah always chuckles when we get to this part. This was the biggest discussion among our committee, and it got a little bit heated, I'd say, several times. So where do you put all the strategies? Where do you put everything you need to think about when you're doing patient education? Immediately, you kind of think, oh, put it in implementation. But as we talked about, we're like, no, wait a second. Before you put anything in implementation, which is exactly when you're doing the patient ed, it really should be in planning. Because you as a healthcare professional need to step back and say, okay, I know this about the patient. I know this is what they're worried about. This is what they want to know. I know they have a learning barrier. There's a auditory, issue or concern. So what are the strategies that I have available? So we actually ended up that the largest part of the guidelines is in the planning section. And in this section, you use all parts of the patient assessment to guide a plan in development and determining mutual education goals. I want to emphasize mutual, mutual, mutual. This is just not, oh, I'm as a healthcare professional, you need to learn this. It hasn't turned out to be effective. I don't know how many of you talk to home care nurses. I have the opportunity to be reminded on a frequent basis of how much patients don't remember from acute care of their patient education. So to me, that is a call alone that we need to do things differently. You determine a teaching plan utilizing evidence-based strategies, which we're going to tell you about, and you focus it on the patient's needs, priorities, and behaviors. And then you identify educational resources to achieve the identified learning goals. So in the implementation phase, really at this point, what you're doing is just implementing everything that was planned based on the assessment using evidence-based strategies. So implementing the teaching plan with the focus on the patient, keep the key principles of patient education in mind, which we're going to look at. Probably the most important part about this is adjust your teaching based on the patient's response and change in learning needs. So you may be talking to a plumber about cardiovascular disease, and the plumber shares with you, I just picked an occupation. The plumber shares with you that I just don't quite understand how the stenting works or what you do here. And so someone who knows anything about plumbing, my father ran his own plumbing company, so I know a lot about this, know that clogged pipes are kind of like clogged arteries. So I would just kind of say, well, when you put the stent in, it kind of pushes that clogged grease and everything out of the way, compresses to the side so you get through, and it remains in there so the blood can flow through. Just like if you would put a pipe inside of a pipe that was opened up, then the water could run through. So that's one of the most important things to remember about the implementation phase.
And then lastly, we have evaluation. And evaluation is really demonstrating the degree to which learning is achieved. What we found in the literature is a lot of evaluation was evaluating the tool that was used, not the supporting that the learner had achieved learning from the education session. So it was interesting to find literature actually focused on evaluation of learning. And the most frequent tools, of course, would be using teach-back strategy, which again is not a test of the patient. It is how well you're explaining it, having them repeat that back to you in their own words, looking at return demonstration if you're teaching some sort of skill, and then measuring if there is a change in the patient outcomes. So the guidelines have been up on the HCEA website, and we did drop that in the chat. So far to date, we've had over 25,000 views to the guidelines as a whole, and then broken down, majority are landing on the home page. Within the API process, assessment and then planning are hit a lot. Evaluation was 32% of the breakdown of the API process and a little bit on implementation. As Carolyn said, we really focused a lot on the planning stage. And the resources section where we've got all the citations of the articles we used, you can see the breakdown as well there. And we were able to pull data of who is pulling, who's reaching out to the website and looking at the content. So we thought this was a great visual just to see that people worldwide are going to the guidelines and looking at the content we've provided.
Sarah, I'm just going to add in here just because we've gotten feedback. We actually did a presentation with the International Health Literacy Association, and we got the list of countries that were involved. And we were in Nepal, Sri Lanka, Germany, Belgium, South Africa. We were around the world. So it was very cool to see that when we did that presentation.
Absolutely. So on the web page, we also do have a PDF listed in case someone wants to print it and have a physical copy. You can print it either in black and white or there's a color option. And we've got about 10, 12 minutes left, Carolyn. So she's going to open up the website to show all of you what it actually looks like.
And I'm just going to show you our last slide because I'm going to exit out of this and just finish off going to the website. Give me 1 second.
And I'll just add that this is a public website. You do not need to be a member of HCEA to access the guidelines. One of our big intents was making it accessible to anyone everywhere.
Yes, the idea was this would be a free resource. And so, okay, so we start here and we talk about the 4 components of the patient education process. Here's the overarching elements. There's the, the homepage you're looking at, frequently asked questions, and then let's go to the assessment section. And these are the 5 steps that you saw before, but here is where you start to get into more the nitty-gritty. And we actually give examples of questions. What do you fear most about your sickness? Do you have any beliefs or feelings related to your health condition that we need to know about? We give you socio-demographics to look at. Here we have what's the current status with the patient. What are you most concerned about? What do you do at home to care for yourself? And then patient engagement on a scale of 0 to 5, 0 being low and 5 being high. How would you rate your confidence that you can follow your instructions and care for yourself at home? What would you do if you had any doubts or questions? So we've set this up so that it's not only the strategy, but how would you implement it or some examples to it? And then learning preferences. There's a little bit of debate about learning style and learning preferences these days. There's some research that is coming out that's saying, Yeah, a patient may say they have this preference, but really they can learn in other styles. We don't have to stick to that preference. So we're continuing to look at that evolving research, and we'll make adjustments as necessary. And then we have specific assessment tools here. For example, patient engagement tools, health literacy tools, the risk evaluation mitigation strategy assessment, and motivational interviewing. And then from there, we go on to planning. And as we said, prepare yourself. This is a long section. But then we talk about mutual goal setting. We talk about individualizing, very important. And any of those who are accredited by the Joint Commission, that is their tune. Where did you individualize their patient education? Show me exactly. I just had a Joint Commission 2 weeks ago. So very fresh in my mind, but they're like, how did you individualize this for your patient? Consider preferred languages, consider caregivers, family members, build on current knowledge. What do they already know? Do we even ask them what they already know to build on it? Or we just start telling them, and if they already knew it, oh well. Motivational interviewing. And then we even divided out here things to consider. And this came from the research, things to consider in different settings. So as you can see, there's a list over here. So this is the references that correspond to that part of the assessment. And then we move on to looking at health literacy, universal precautions. Here's other tools that they can look at: oral and written plain language, the CDC clear communication. Once again, use simple direct messaging, avoid medical jargon, use common everyday language. As you can see, there's a big overlap between what you heard in the first presentation and our presentation. It goes hand in hand. So that's the good news, is we're all seeing the same thing in the research. Identify content, key messages. Once again, keep the message focused. Focus on what's absolutely necessary for the patient to accomplish their behaviors. Employ effective communication strategies, promote self-efficacy, use team-based approach, use a multimodal approach. This came out loud and clear through a lot of the research. So don't just verbally give the patient information. Give it verbally, give it written, give it verbally, give it in text, give it in a text, give it written, give it in a video, give it written, give it in verbal, and then follow up with a video. Multiple ways of doing this, but this came out very loud and clear in a lot of the interventions. Use multi-sensory approach. Can they hear it, feel it, touch it, look at it? Now, a multi-prong approach, you're like, okay, multimodal, multi-prong, we got a lot of multis going on here. The multi-prong really applies to if you're presenting. I'm an ortho background, so we give joint replacement classes all the time. So at this point, people are really doing multiple ways of doing it. Some people are doing a webinar, some patients have a choice of doing a webinar. They have a choice of reading a booklet. They have a choice of attending a class in person. So it's really good to offer things in multiple ways to kind of suit whatever the patient needs for whatever reason. Have repeat contact. I think we all know, reinforce, reinforce, reinforce. Use problem-centered learning. Okay. It says here, a patient can demonstrate what to do when blood sugar is too high or too low. Use
Carolyn,
I'm sorry, Sarah.
I hate to interrupt. We're getting the hook that they would like to move on to Q&A. So if you want
Q&A.
to just wrap up.
Sounds very good. And I just want to show you evaluation here. And then once again, we have appendices. Lots of resources, and then the references, and then the quick guide is here. And then the last thing is you're welcome to print off a black and white or color right from our website. So thanks for giving me the hook. I'm now going to shut out my screen, stop sharing, and I think we're moving on to question and answers.
I just want to say that wasn't me. Okay. Don't blame that on me. Okay, so Mario was kind enough to open up the chat for everyone. And I also have a couple of questions in the chat box for questions and answers. Let me try to find them. Okay, so I think the first one says, was there diversity or other criteria in choosing reviewers? And I think that Sarah and Dr. Cutilli, it was early on your presentation that you were talking about this.
We did. We had 27 volunteers, including a patient volunteer, and we had a wide range of disciplines. But as you're looking at a multi-year project and finding volunteers, we were really pleased to get the the variety that we did not specifically recruit for diversity. Carolyn, I don't know if you want to answer anything else.
I was going to say, as far as diversity of healthcare, we had pharmacy, we had dietitian, we had nursing, we had medical writers, we had librarians, we had physicians. Who all am I forgetting? And our patient, I have to tell you, our patient passed away. He was actually a lung transplant patient from Penn who was so grateful for what was done for him that he volunteered all the time. He worked with me all the time. The day he died, my world, kind of fell apart. But Gary stuck with us for 2 years through this process and constantly reminded us of who this project was for and what it should look like. Now, it was for professionals, but the bottom line is who the patients were for. So hopefully that answers that. And we had diversity in background as far as race, age, education, although we did have a tendency to be a higher educated group because we were healthcare professionals, but we did try to keep all that in mind.
How about diversity in race and culture and ethnicity?
We did have people of various backgrounds, and they were from all over the country. Sarah sits in Texas, I sit in Philadelphia. There were people who were in Utah, California. The one physician was from Vermont, if I remember correctly. She was from Vermont. We had people from the southern part of the United States. So they did have all different cultures and backgrounds. And we really set the guidelines up to try to avoid. So it was interesting because people said to us, they didn't think we were culturally sensitive enough with the guidelines. But we took the thing of get to know your patient. That's what really matters. Know your patient, use these questions, use this to know your patient. So then you can adjust to whatever is in their background that will help them learn. So just want to point that out.
Thank you. Noelle, do you have a question in the Q&A? And I think you were typing up an answer, but not everyone can see it. So I'm going to read it out loud. It says, how would you frame the messaging when the health outcomes are directly related to a person's weight? For example, if you were trying to teach viewers that a larger body weight has a direct impact on the longevity of a total knee replacement, would you say a phrase like people who are overweight or people who have a higher BMI?
That's a great question. I'm going to kind of pull it apart because there's kind of two different pieces that I'm seeing here. So one question is just in general and talking about people at higher BMIs, people that are overweight. That terminology can vary person to person. I think just as Carolyn was saying, there are some individual preferences. For example, one component related to all of this is, fat phobia. And as a community, some people do not shy away from referring to themselves as fat. As a society, we tend to shy away from that term and assume that it is always negative. But I just mentioned that there's going to be individual differences on how someone might refer to themselves and how they might want to be referred to or have, characteristics talked about. That being said, that Yukon RUD resource will have some good examples of, there's person first language, people with obesity, people with a larger body, people with a higher BMI. Those all are typical ways of saying, as opposed to, obese people. So any of those would work. But then the other thing that the other piece of the question has to do with kind of that direct patient interaction and communicating about the potential impact about body weight on a total knee replacement. And so I'm definitely not an expert in that procedure and everything that goes along with that. But one thing that comes to mind for me in thinking about potentially weight stigma is, is the information very necessary? Is it a need to know? And is it being explained in the context of other things that might impact the longevity of a total knee replacement? And being mindful of the cultural implications, right? So knowing that even if we're being kind and respectful in our language, that mentioning that someone's weight or size and an implication related with their health could be very sensitive, and something that just bringing up could be felt stigmatizing and upsetting in any way. So I would say just thinking about if we're communicating this in a way that is absolutely the necessary information, and are we communicating it in a way similar that we would to someone in a smaller weight body? Are we explaining the same considerations that might be at play so that you avoid a situation where someone feels like I'm being targeted because of my size, that I have to have the specific interaction and communication that my weight is going to have a negative impact. So I know that's kind of a vague answer, but there's sort of complexities and nuances to take into consideration there.
Thank you. And my internet just dropped. I was like, uh-oh. Okay, well, thank you about that. I have a comment in the box as well. It says that do you questions. Sometimes it only allow for a yes or no answer. I like using more of a tell me about to encourage dialogue with patients. And I don't know if you guys have any comments about that.
It's too bad you only have a yes or a no. And I think if that's your situation, lobby your organization to make changes to the intake form and that assessment. We've relooked at ours numerous times and have expanded things to free text box when it really is applicable to be able to individualize for the patient.
I think that was caught in one of our examples on the guidelines. So duly noted that open-ended questions definitely will elicit more response.
Yeah, we have some comments on the chat. I think you guys can see it now, about how culture it really tells you what's accepted when it comes to weight. What's healthy, what's not healthy. I'm from Colombia, and when you're skinny, they tell you you're sick. You need to eat. You need to fatten up. If you're too skinny, you're not healthy. So I totally get that from my own perspective, and my mom is like that. She will feed me until seriously, I will explode. And if I go home and she sees if I'm too skinny, she'll tell me what's wrong with you. So we have some comments in the chat box about being mindful of the culture of the people that we're serving.
And I think that's one of the keys that we really emphasize with that is get to know the patient. Critical.
Yes, and I just want to tag on to that, getting to know specific audience needs, but I think also that highlights that I mentioned weight stigma, and there is a big impact on people with higher weights, but across the board, weight and body size can be stigmatizing for anyone. And people all across the board struggle with body image or feelings of shame and guilt if there's a perception that their body is too small or too big or too this or too that. And so always being mindful, whatever the case may be, and how we're communicating our messages, and is the weight relevant? Is the weight having to do with the health behavior, or is there something else that we can turn our attention to?
Thank you. And I'm being yelled at because I'm now managing the time, and the next session starts in about 1 minute. So thank you so much for everything you guys presented today. Great presentation. We appreciate your time. Thank you so much.
Thank you.
Okay, bye-bye.